So now you're ready to deal with that cold, clammy patient who was pulseless and whose relatives were not letting you stand there in peace. Now you know what is wrong with that patient, what is the classification of shock, what would happen if you would do nothing. So now comes your action, how you will resuscitate this patient. So the resuscitation in this section will follow various guidelines for resuscitation of patients with shock. We'll try to see what is the proper fluid therapy or the proper fluid management, and then we'll talk about the vasopressors and inotropic support. So first of all, the resuscitation of the patient himself. So the timing and the nature of resuscitation will depend upon the type of shock, obviously, and the timing and severity of the insult. Pretty obvious. The reason we talked about various kinds of shock is because the management of various kinds of shock is different. So you first have to assess the type of shock and the duration and severity of the injury or the shock itself. That is important in making a decision that how you will resuscitate the patient. So first of all, do a rapid clinical examination, check for pulse, check for pupillary response, check for breathing, check for airway. So we have this airway, breathing, circulation, then you check for the blood pressure or all the vitals or the pupillary response, etc. Now if you don't have sufficient time, or if you are in doubt as to what kind of shock this is, always assume it's hypovolemic shock as it's more common. Now begin with the fluid resuscitation. You have to start with fluid resuscitation straight away. So you have to maintain circulation first. Circulation first is the protocol. So first of all, you'll check for circulation, then for airway, and then for breathing. So CAB is the international protocol to maintain shock. You first check for circulation, you start circulatory fluids, you check for airway. If there's any obstruction in the airway, you try to relieve it. You check for breathing, if the patient is breathing spontaneously or not. Now you assess the response to this fluid. Whatever fluid you are giving, you see how the patient is responding to that fluid. It is very important to assess the response of the patient because in hypovolemic shock, the patient usually improves with fluid therapy. However, if it's distributive shock, the patient would not improve with fluid therapy. So we have to see what type of shock that is and what is the fluid therapy doing to the patient. Now the conduct of resuscitation. Now in patients you have to maintain that you have to find out the kind of shock that you're dealing with. So if a patient is actively bleeding, it's counterproductive to institute high volume fluid therapy without controlling the site of hemorrhage. So let's say you are giving fluids, you're giving blood to a patient, and the patient is actively hemorrhaging at the same time. So it would not do any good. You have to control the site of bleeding at once. Call for a trauma surgeon. Try localizing the site of injury, the site of trauma. Once you've localized the site of trauma, try to control the bleeding from that site. If you control that bleeding, the shock would be controlled itself. Now, operative hemorrhagic control should not be delayed at all, and resuscitation should proceed in parallel with the surgery. So you get a patient, let's say you have a RTA, a road traffic accident, and actively bleeding. A patient comes to you who's bleeding within the abdomen. How would you see? There would be free fluid in the abdomen that would be assessed with an ultrasound. Now, this free fluid requires urgent laparotomy. The surgeon laparotomy has to be done urgently, hence the word urgent. So it has to be done urgently by a trauma or a general surgeon. So the attempts on resuscitation should not delay this hemorrhage control, operative hemorrhage control, because no matter how much you resuscitate this patient, if you're not going to control the volume, the resuscitation would not be effective. Now, In patients with bowel obstruction, hypovolemic shock. So they have hypovolemia. These patients have hypovolemia as well, but they have bowel obstruction. That is third space loss. So they must be adequately resuscitated before undergoing surgery. So there's a difference. So in patients with bowel obstruction, how do you assess bowel obstruction? You'll look for the bowel sounds. The bowel sounds are absent in bowel obstruction, and they must be adequately resuscitated before undergoing surgery. Otherwise, additional surgical injury and hypovolemia induced during the procedure will exacerbate the inflammatory activation. It increases the incidence and the severity of the end organ insult. So in patients with bowel obstruction, it is necessary to resuscitate them before sending them off to surgery. Now, talking about fluid therapy. So how do you maintain the fluid therapy? So first line fluid therapy is the first line therapy. Intravenous access and administration of intravenous fluids is done. Now, administration of inotropic or chronotropic agents to an empty heart is done. Now, this leads to rapid and permanent depletion of the myocardium of oxygen stores. They deplete the oxygen of the myocardial stores. This reduces the diastolic filling, as a result of which there is reduction in the coronary perfusion. This can lead to unresuscitable shock. So you have to be very careful in your fluid therapy, as it can worsen your shock as well. Now, access should be through short, wide bore catheters that allow rapid infusion of fluids as necessary, because the patient is in hypovolemia. So you'll be needing to it would be required of you to give a lot of fluids. Long narrow lines such as central venous catheters, they are not good for resuscitation, because you cannot give voluminous fluids through those lines, and they are good only for maintenance and for pressure, for measuring of the pressures. Now, the types of fluids. So there are two types of fluids, the crystalloids and the colloids. The crystalloid solutions include the normal saline, the Hartmann solution, and Ringer's lactate. The colloid solution include the albumin and the commercially available products. So there's a lot of debate on the use of crystalloids and the colloids. I'm not going into the detail of the crystalloids and the colloids. They can be assessed as per the hospital protocol. Now, this is the dynamic fluid response. So first of all, we evaluate the vital signs. We give the fluid and check for the rapid response. The vital signs, if they come to normal, your fluid therapy is good. Now we check for the transient response as well. Transient improvement, then the fluid therapy is good. And no response, it remains abnormal, it is inappropriate to continue the fluid therapy. Now, if the patient responded rapidly, there's minimal loss of the fluid in the patient, that is 10 to 20%. In transient response, there's about 20 to 40% loss already, and the loss is ongoing. So it's important to evaluate that patient for the loss, that is for the hemorrhage. In severe loss, in patients who do not respond to fluid therapy, there has been severe loss and they might already be in the decompensated stage. Now, need for more IV fluid. In rapid responders, it's low. In transient responders, it's high. In no response, it's higher, obviously. Now, need for blood is low. Now, it should be typed and cross-matched. In transient responders, the need for blood is moderate. You see, if the patient is not improving on fluids, you might infuse the patient with the blood. Now, it should be type specific. And in no responders, the immediately massive transfusion protocol must be ensued, and you do not type or cross match the blood. You give O, which is a universal donor, you give that to the patient immediately so that the patient might be resuscitated. Now, the need for an operating room, it's possible in rapid responder, it might be required. In transient responders, it's likely because they are bleeding from somewhere, there has to be control. In patients who are not responding, it's high because they need to go to the OR to control the bleeding and maybe save the life of the patient. Now let's talk about the vasopressors and the inotropic support. So they're not indicated as a first line therapy in hypovolemia. So sometimes they're helpful, sometimes they're not. Let's see. So the vasopressor agents, they include the phenylephrine and noradrenaline. They're indicated in distributive shock, in which there was pooling of blood in the vessels, as occurs in sepsis, as occurs in neurogenic shock, where there's peripheral vasodilation, we've talked about it, and a low systemic vascular resistance. So in these conditions, the vasopressor agents are used, where the vasodilation is resistant to the catecholamine. So this is another condition in which the vasopressor agents, the phenylephrine and noradrenaline, are used. Now, the inotropic therapy is used in cardiogenic shock, or where myocardial depression has complicated a shock state. So, two conditions, cardiogenic shock itself or myocardial depression. In these conditions, the inotropic agents are used. There's increase in the cardiac output and therefore oxygen delivery. These inotropic agents, they cause an increase in cardiac output and increase in the oxygen delivery to the cells. Now, enodilated dobutamine is the agent of choice. So the enodilated dobutamine is the agent of choice as the inotropic therapy. So this was all about this section. Now you have learned to manage a patient of shock. Always go in your emergency department and ask your attending or your physician to help you, guide you, to help you understand, or at least just go there and see how a patient in shock is being managed. It's a very practical, hands-on experience that requires a lot of nerves. So I would like you to be prepared for whenever that doctor, that ER doctor is you and the patient comes to you. And believe me, that would happen. So for further sections, keep watching sqadia.com.